Hi dear doctors, welcome to 𝗲𝗵𝗵𝗵𝗺. Myself Dr. 𝗵𝗵𝗵𝗺 and I am your pediatric faculty. In this topic of today, we will discuss about the atrial septal defect. Okay, so for your information, let me just rewind that we were discussing pediatric cardiology, and in pediatric cardiology, this is going to be our third class, which is atrial septal defect. Okay. So atrial septal defect, for example, I've deliberately added a case study for you. Let us just understand about this after the discussion of atrial septal defect. So what is atrial septal defect? Please understand that, in the normal embryology, okay, so if I just focus on this normal embryology, please understand that in the development of heart, there is something which is called as septum primum. Okay, there is something which is called as septum primum. So septum primum is going to grow caudally from the superior portion of the common atrium towards the endocardial cushion. Okay, so if I just show you, this is the endocardial cushion. Okay, this is the endocardial cushion, and there is a septum which is going to grow from the caudal end to the endocardial cushion. Okay, so septum primum is going to grow caudally from the superior portion of the common atrium towards the endocardial cushion. Okay, then after the growth, what happens, it fuses with the endocardial cushion. Okay, so it is going to fuse with the endocardial cushion. Then what happens is that there is something which is called as ostium secundum. So till now we were discussing about the septum primum. Okay, and what happens is, please understand, once the septum primum is going to fuse with the endocardial cushion, the gap between the two, this is the gap between the two, which is called as ostium primum. Ostium primum. So any gap, any space, any hole, it is called as ostium, right? So here what is happening, the septum primum is going to fuse with the endocardial cushion, and it is going to close this gap, and this gap is nothing else but the ostium primum. So my dear friends, please understand that septum primum, once it fuses with the endocardial cushion, it is going to close the ostium primum. Then what happens, look at this blue color, a second orifice. Okay, there is before telling you about the second orifice, please understand about the ostium secundum now. Okay, so what is ostium secundum? Ostium secundum is something that is going to develop within the septum primum. Okay, so in the septum primum, there is another hole which is coming, and that another hole is called as septum, that is called as ostium secundum. Okay, so a second septum is going to come, that is called as septum secundum. Okay, that develops on the right atrial side of the septum primum. Okay, develops on the right atrial side. Okay, so let me just quickly rewind it for you, because I know, in fact, I sometimes get confused while discussing this topic. So I've just told you that this is the septum primum. This has to fuse with the endocardial cushion, and it is going to close this gap, closure of the ostium primum. But then what happens is, then in this septum primum, the red color one, there develops a hole that is called as ostium secundum. That is called as ostium secundum. Okay, but what happens next is that the septum secundum covers the ostium secundum but does not completely divide the atria. Now can you see carefully what is happening? This blue color one is the septum secundum that is going to develop, and this septum secundum is going to cover the ostium secundum. Okay, it is covering the ostium secundum, but one thing which you have to understand, that this is not dividing the entire of the atria. Septum secundum cannot divide the entire of the atria. Okay, so this is just a normal embryology. Okay, you got it? Yeah. But now what happens is, for example, if your orifice is persisting, the persisting orifice within the septum secundum. Okay, so there is a persisting orifice within the septum secundum. Can you see this? Yeah. So this is a persisting orifice in the septum secundum, between the light blue ones. Okay, is called as foramen ovale. This is called as what? This is called as foramen ovale. So now you can understand what is foramen ovale. So foramen ovale is nothing else but a gap. It is a gap. Okay, so it is a gap between the septum secundum. Actually this gap is normal. Okay, actually this gap is normal. Okay, this septum secundum is going to fuse, okay, by the 2 years of the age anatomically. Okay, anatomically it is going to fuse by 2 years of age. Okay, but in 20-30% of the population it is still patent. Now what is the benefit of foramen ovale? So what happens is, if I just try to tell you what happens is, for example, this is the heart. Okay, let me just show you, and this is the left side of the heart, this is the right side of the heart. What happens in infancy, the lungs are not very mature. Okay, in infant period the lungs are not very mature. So what happens is, because the lungs are not very mature, so the most of the blood, whatever comes onto the right side via the help of this foramen, is going to go to the left side. Because if it is coming onto the right side, it has to go to the lungs, and since lungs are not mature, there's no point of sending much amount of blood to the lungs. That's why it goes to the left side, and from left side it is poured into what? It is poured into the systemic circulation. Alright, it's clear? Yeah. So foramen ovale is this, but sometimes it remains patent also. Sometimes it remains what? It remains patent. So I think now we are in a good state to understand about the atrial septal defect. Of course, we'll discuss about the case presentation, but after a while, let me just introduce you. This is a acyanotic congenital heart defect. Now, if it is patent, what is going to happen? Please understand. If it is patent, what is going to happen? Again, I'm drawing the same diagram. For example, this is the left side, this is the right side, and there is a patent hole which is present here. Now, you very well know that after the birth, the left side musculature is very, higher on the left side rather than right side. So the blood from the left side is going to go to the right side. Okay, ultimately it is going to reach to the lungs. So that's why, because it is reaching to the lungs, this heart defect is actually a acyanotic heart defect. Okay, cyanosis develops if there is no oxygen, there is reduced hemoglobin, but here, because it is going to the lungs, it is getting oxygenated. That's why it is a acyanotic congenital heart disease. Please remember that ASD is a second most common congenital lesion. So first comes VSD, then comes ASD. How to remember? So ASD coming after VSD. Okay, and V for 1 is ONE1. That means it is the first most common. This is a method to remember VSD as well as ASD. Now this gap can be in septum primum. So one type is actually primum, other can be secundum. Okay, one of the other types can be opening into the coronary sinus, so type is coronary sinus. Then can open into the sinus venosus, so it is the sinus venosus. Okay, so these things you must know. Okay, coronary sinus, sinus venosus, what are these things? So just give a quick revision from the subject of anatomy, or if you want a detailed discussion on this, just type in the chat box. I'll discuss this topic for you. So I have told you this. Let us just quickly revise that septum primum grows towards the endocardial cushion, then it closes the ostium primum, but ostium secundum is formed. Okay, that is covered by septum secundum, and the gap in the septum secundum is called as foramen ovale, or it is actually fossa ovalis also. So what happens is, foramen ovale is going to allow the right to left flow in the fetus, which closes at birth because the left atrial pressure is more than right atrial pressure. Okay, now if you see here, the word written is fossa ovalis. It is not foramen ovale. Okay, it is not foramen ovale. So foramen ovale is just the opening. Okay, foramen ovale is just the opening, whereas fossa ovalis is the covering of that opening. That is actually formed by what? That is actually formed by septum secundum. So that's why fossa ovalis is what? It is the septum secundum which is surrounding the foramen ovale. Okay, now failure of closure. Just like I've told you that 70% is going to fuse during the infancy, but yeah, of course, if it is not covered, then it is called as patent foramen ovale. Okay, patent foramen ovale. So classification, primum, secundum, you very well understand. What about sinus venosus? Sinus venosus is something, you very well know that the 𝗧𝗲𝗹𝗵𝗵 is, they are going to enter into the right atrium in the sinus venosus. So if they are entering abnormally out there, that is one of the type of ASD. And what is in coronary sinus? So that's actually a defect between the coronary sinuses and the left atrium. Alright. So what is the pathophysiology? Please understand that now the left to right shunt is going to come. So an oxygenated left atrium blood is going to go into the right atrium. There will be increased amount of blood in right atrium and right ventricle. That's why the right atrium and right ventricle are going to dilate. And once they are dilated, what is going to happen? There will be pulmonary vascular remodeling. That means a lot of blood is going to enter into the lungs. Okay, but what happens is, what is the problem? Now, first of all, there will be pulmonary vascular remodeling. Okay, there will be a lot of blood that is going to come into the pulmonary vessels. So pulmonary vessels can undergo pulmonary hypertension and some changes. Then a lot of blood is going to go to the lungs, which is called as plethora. Okay, plethora is increase blood to the lungs. Okay, increase blood to the lungs. And the third important, or rather than most important thing, what happens is that the blood leaving the left ventricle, although it is oxygenated, but then the cardiac efficiency is going to get reduced. Okay, the cardiac efficiency is going to get reduced. So these are the three important changes which you have to understand. Now, what is happening? Please understand, if there is a very small ASD, that means a very small amount of blood is going to come from the left side to the right side. So small ASDs are generally asymptomatic. Okay, generally asymptomatic. Incidentally, you might find a murmur or something like that. Okay, but if it is a large ASD, it can cause failure to thrive. Why failure to thrive? Because of less oxygenation, less amount of blood reaching to the tissues. So failure to thrive is going to be there. Then the patient might have recurrent infections. Why recurrent infections? Because of course, the blood is not reaching. So the immunoglobulins can't reach to the particular tissues, and even a minor amount of infection can cause a lot of problems, right? Then in some cases, it might cause heart failure also. Okay, but it is rare. It can cause heart failure. Why? Because heart has to do a lot of work, okay, to compensate the less amount of blood which is reaching the left ventricle. Okay, so in order to compensate, it has to do a lot of work. And of course, the oxygen demand is increased, but the oxygen is not reaching properly to the circulation of the heart itself. The heart might have a heart failure. So what are the other complications? I've told you, pulmonary hypertension, and of course there can be a paradoxical embolus which can be there. Okay, paradoxical embolus can be there. Actually, what happens is, why there is embolus formation? Because a lot of blood is going to go to the right ventricle. Okay, so because of a lot of blood reaching to the right ventricle, a lot of blood is reaching to the right atrium, the blood is going to be there for a longer period of time, and it can cause the injury also. Okay, so I've told you that it can cause an injury to the pulmonary vasculature, because a lot of blood is gushing. Okay, and that injury, endothelial injury, can lead to thrombus formation, and of course the thrombus formation can dislodge. That is called as paradoxical embolus. Okay, now what will be there? What will you see? There is a wide split S2 sound. This is extremely important. Wide split S2 sound. What does this mean? So coming on to this wide split S2, see, understand what happens is that there are four systolic sounds: S1, S2, S3, S4. S2 is actually the closure of the semilunar valves. Okay, so A2 and P2 are going to close. So A2 means what? A2 means there is a closure of the aortic valve, and P2 means that there is a closure of what? Closure of the pulmonary valve. Now you are smart enough to tell me that which side musculature is stronger. Of course, left side musculature is stronger. Now because the left side musculature is stronger, what is going to happen? It is going to empty the blood very early. So the A2 is going to be produced very early. Can you understand this? Because the left side musculature is strong, the left side is going to get empty very early. That is why A2 is going to get produced early, because the doors are going to close once the blood is out. So A2 and B2 normally have some gap, that is a physiological gap, normal delay. But what happens in case of your ASD? What happens in case of your ASD? So understand, a lot of blood is going to go to P2. Can you understand? A lot of blood is going to go to the right side, and lot of blood is going to go to the right side and a less amount of blood is going to go to the left side. So the aortic opening is going to get closed even earlier as well, and the pulmonary is going to close even later. Okay, so pulmonary is going to close later, aortic is going to close earlier. That is why this gap is going to get increased. That is why there is a wide fixed S2 split which is going to happen. Okay, you got it? Great. And now please understand that, even while expiration or inspiration, in both the cases, if there is an atrial septal defect, nothing is going to change. Understand this. During expiration also, during inspiration also. What the whole point is that, the amount of blood is going to change, okay, during expiration or inspiration if the intrathoracic pressure is changing. Can you understand this? Because when we inspire, what is going to happen? There will be a lot of negative pressure which will be generated intrathoracic. That is going to increase the blood flow to the right side. Okay. But what happens in this case in atrial septal defect? Even if you are increasing the blood on the right side, it is ultimately going on to the left side, and then from the left side it is going to the right side. There is no major change which is going to occur in the split. So that is why this is a fixed split. Okay, this is a fixed split. All right, so yeah. So I think now we are well versed with what do I mean when I say that it is a wide fixed S2 split. Coming on to which murmur you are going to see. So there will be systolic ejection murmur. Okay, systolic ejection murmur. Okay, at the left side second intercostal space. Okay, but yeah, of course there is no thrill which will be there. Now can you tell me why there will be an ejection systolic murmur? Because see, understand, murmur happens when the blood flows from a high to a low area or high to a low volume area. Okay, so what you have to understand in all of this is that a lot of blood is going to go from the higher side to the lower side. And what is the higher side? Higher side is the right ventricle. To a lower side, which is the lower side, it's actually the pulmonary artery. Okay, that's why there is a ejection systolic murmur that is going to occur, and that has to occur on the pulmonary area. So where is the pulmonary area? Pulmonary area is nothing but the second intercostal area. But please remember, there is no thrill. Okay, there is no thrill. Okay, and of course the right ventricle impulse is going to be hyperdynamic. That means a lot of blood is going to come from the right ventricle ahead. Okay, now how will you diagnose it? It's very simple. You have to perform an echocardiography. Okay, you have to perform a echocardiography, and echocardiography is actually a gold standard thing in order to see what are the changes in the atria. Okay, so atrial septal defect is actually a septal defect, so you have to do a ultrasound of the heart to see the defect, right? And there is something which is called as TEE, transesophageal echocardiography. For the sizing and the surgical planning you have to do. Okay, so transesophageal, let me write down, transesophageal echocardiography. In chest x-ray, right atrium and right ventricle will be enlarged, and of course the pulmonary markings are going to be very prominent, which is called as plethora. Okay, which is called as plethora. I think I've got some of the, see here, this entire part is the enlarged right ventricle. Okay, and there are a lot of haziness. Can you see this? A lot of haziness. Why this haziness? Very simple. See, if it would have been air, okay, if it would have been air would have been black in color. Because there is blood is actually white in color, so you can see the prominent white markings over here, right? So a lot of blood is going to the lung fields also. You got it? Great. Now one more important thing is Eisenmengerization syndrome. This seems to be a very fancy thing, Eisenmengerization, but there's nothing. Eisenmengerization is just like in normal individuals, what happens is that the right side and the left side blood is going to go into the right side. But what happens after a period of time, that the right side musculature, okay, so if the right side musculature is even turning stronger than the left side musculature, this is going to allow the blood to go from the right side to the left side, and this is called as 𝗖𝗵𝗵𝗺ization syndrome. Okay, so what will happen in 𝗖𝗵𝗵𝗺ization? Less amount of blood will be going to the lungs. That is why 𝗖𝗵𝗵𝗺ization is going to have cyanosis, because of course, you know, all the blood which is coming onto the right side is going to the left side, so very less amount of blood is going to come to the right side. Okay, also it is responsible for causing pulmonary hypertension, right-sided heart failure. It can even cause arrhythmia. And you know, if you remember, arrhythmia, if it is happening, it can cause injury, and once there is injury, it can lead to thrombus formation, and from this thrombus it can lead to embolus formation also, and then it can go to the brain. Once it is going to the brain, it can cause what? It can cause stroke over there. Okay, so what is the treatment? The treatment modalities is, if it is small, like less than 8 mm, okay, so 8 can be written as 8, okay, so A for atrial septal defect. So if it is less than 8 mm, it may close spontaneously by just you know, you can say 1 year or something like that. Okay, but for example, if it is not closed, you have to insert a device that is called as percutaneous device closure, or you can have a surgical repair as well. Okay, you can do a surgical repair also. Okay, so yeah, okay, so there is a surgical repair, surgical modality also available. Okay, alright guys, so now it's the correct time to understand about the case presentation. So what is there in case presentation? A 1-week-old infant is brought to the pediatrician's office for a general checkup. He was born without complications at 39 weeks gestation to a 𝗲𝗵𝗵𝗺 mother. His temperature is 37, that is normal. Pulse is 130, that's normal. Respiration is 28, it's absolutely fine. Blood pressure is 72/54, that's also normal. Currently at the 50th percentile of the weight, 75th percentile of the height, considered quite normal, not very normal. He is acyanotic, 1 clue. He is having systolic ejection murmur, 2nd clue. Over the second intercostal space, that means it's a pulmonary systolic ejection murmur without an associated thrill. There is no thrill which is there. S1 split is with loud second component and best heard over the left second intercostal space. Okay, remainder of the examination is unremarkable. So very simple, you know, there's a 1-week-old infant, acyanotic, systolic ejection murmur, second intercostal space, right? And there is a wide split S2. So the most probable diagnosis is going to be what? It is going to be ASD, right? So I think all the things I have covered in this PDF. Yeah, right. So now there is a last question for you people. Okay, just let me know, ward in surgery is done for what? Okay, that's a bonus point. Ward in surgery is done for what? Okay, for what purpose will you do the ward in surgery? With this question, I leave you guys in this video. We'll meet in the next video. God bless you. Thank you.